Hello. So today we want to discuss a very important topic, that is errors in nursing intervention in critically ill patients. Less is more. That is, sometimes doing less is better than doing more. So we have to be very careful when we are doing certain intervention to a patients. In the treatment of critically ill patients, evidence-based nursing practices are essential, highlighting the need for precision procedural management. This discussion identifies the 9 common mistakes, the errors encountered in clinical practice. So this, look and listen to it very attentively. Okay, look the slides and read the slides thoroughly and listen to it and learn from it very attentively, because it will help you a lot in futures in managing your patients better. Okay, also this is I have taken it from a article which is published in health management healthcare.org. It's a community which is best in Europe, and it is a community of very good practitioners practicing in Europe, this community is for giving best healthcare to the patients and best knowledge also to the healthcare professionals. So do listen, do read about these errors, nursing errors, which we intensivists also, or the nurses, used to do frequently. Okay, so have a good idea about it. Next slide. First mistake, routine endotracheal tube secretions aspirations. That is, when we do suctioning, it's an invasive procedures. It might cause trauma to the patients, it might cause hypoxia, it might even cause cardiac arrest. So you have to be very careful when we do a suctioning to the patients. That is, you do only when it is required. That is, when we can see there are a lot of secretions in the tube, or we can see that there is crepitations in the chest, or there will be in the ventilator you can see the airway pressure high. In those conditions you do suctioning. Okay, so when implementing the suction technique, adhering to best practice is very important. Suction should be performed based on clinical need rather than a routine schedule to avoid unnecessary risks. Don't do suction as a schedule. Okay, do only when it is required clinically. Rigorous hand hygiene is essential both before and after the procedures to prevent the transmission of infections. So before and after doing suctioning, a rigorous hand hygiene should be practiced, because doing this, it will prevent the spread of infections to the patients. That is, it will prevent the cause of VAP to the patients. So while doing your suctioning, always do hand hygiene, always do hand rub with chlorhexidine, or you can wash it in front of the tap with a soap and do the suction, right? Next, the suction process should not exceed a maximum of duration of 15 seconds. That is, within 50 seconds do suctioning and come out. And the suction pressure should be 80 to 150 millimeter to ensure efficacy and to reduce the trauma. Keep the suction pressure between 80 to 150. Next, do suctioning with appropriate size catheter to increase the comfort of suctioning to the patients, and monitor the sterility of the catheter and ensuring the suction systems remain closed. The suction system should be closed throughout while you are doing suction. And lastly, document it in your nursing chart that you have done suction. Next, bronchial lavage. The American Association for Respiratory Care and the American Association of Critical Care Nurses have advised against routine application employment of bronchial lavage. That is, when you do suctioning, sometimes you give normal saline, or sometimes we give soda bicarb. This is not good. This is not required. There's some disadvantages in doing this. So the finding has suggested that in doing this, it causes reduction in oxygen saturations that notably prolong the recovery time back to the initial level. Okay, a decrease in arterial pH is also noted, an increase in secretion volumes, a rise in heart rate, and elevation in SBP is also noted. While we give normal saline in doing suction, you do it directly, don't put anything. Okay, normal saline or like this. It also causes It might also increase the chance of infection to the patients. So routine use of bronchial lavage like normal saline, soda bicarb should not be done. If if you are suspecting some blockage in the catheter, in the tube, then you might do, sometimes you might put on some soda bicarb, or you can put on an acetylcysteine, but otherwise don't do it routinely. Next, oral hygiene with chlorhexidine or prevention of BAP. Since many years we have been using oral hygiene with chlorhexidine, we used to do, but it has been seen that doing this, it causes some adverse effects, like it causes some erosions, oral erosions also to the patient, also formation of certain ulcers, formation of certain white and yellow plaques to the oral cavity to the patients. Okay, so oral hygiene remains very important, but the latest recommendation is against using chlorhexidine. Now it has been recommended that oral hygiene should be done by using a mechanical brushing of teeth using standard toothpaste. That is, brush the teeth as we do daily with using a standard toothpaste, and regular moistening of the oral cavity, and keep the oral cavity moist. Don't allow it to be dry, because it might cause injury to the oral cavity, it might cause increased ulceration. So keep it moistened and brush it with mechanical toothpaste and using the normal toothpaste. Okay, these practices are critical not only for the prevention of respiratory infection, but also for the overall well-being of the patients. So these practices are also beneficial for the well-being of the patients. Routine gastric residue management, that is, the latest ESPN guidelines is saying that feeding should be done as early as within 48 hours to the patients, and within 3 to 5 days fill up the total calorie requirement. But we do aspirations, gastric aspirations before feeding to the patients, so routine aspirations. But these aspirations, how much amount has been aspirated, depends on where the tube is placed, depends on how the position of the patients, depends on the tube size, depends on the nursing professionals who is doing this. So it is very variable. So it is no use doing routinely aspirations, gastric aspirations. So continuous monitoring is associated with a lower nutrient. Ultimately, patient resulted in lower calorie intake. This harms the patients. So don't do it. Do it. Just check for whether there is any abdominal distension, whether patient is complaining of abdominal pain, or there is repeated vomiting. In that case, you might do, or you might stop feeding, but don't do routine suction, routine aspirations. Calculation of insensible loss. It is also very important to calculate the total intake and total output of the patients. Total intake includes bronchial tube feeding, the IV fluid, and all. Total output includes the urine output, the drains, you have ultrafiltrate from the dialysis. All these are total output. But in doing this total intake and total output, don't calculate the insensible loss, because it might be variable. So just calculate total intake and total output. Okay, total intake, you have to calculate it, you have to confirm it 2 or 3 times before writing it on the chart, because sometimes it might be a mistake, and doing this mistake will cause a lot of harm to the patients. So very careful when you're monitoring this. Fluid accumulation is a state of positive fluid balance which may or may not coincide with fluid overload. A percentage of fluid overload adjusts to body weight. There is one formula where we can calculate the percentage of fluid overload which is adjusted to the body weight of the patients. So in doing this, if the percentage is more than equal to 10%, then we say that patient is having fluid overload. There is a formula which we can find out in internet. If you search, you can find out. By doing this formula, as per body weight of the patients, you can calculate the percentage of fluid overload. In that case, you can come to a better decision that patient is having fluid overload. Sometimes it is seen that patient is having fluid overload in the chart, but patient is not having any crepitations or any sign of other fluid overload. In that case, we might continue with the fluid. Next, bladder exercise, urinary catheters removal. Give catheter only when it is required. That is, when the patient is having urinary retention, when the patient is having we have to monitor the urine, or when the patient is in shock. In all these cases, you have to apply the catheters, but don't do it routinely. In normally passing urine a patient, normally patient who is passing urine, no need of doing this. And moreover, when you remove it, don't clamp it and remove it. Remove it directly. Now it has been a old practice that we used to clamp and see the volume, ask the patient whether patient is having sensation, and then we remove the catheter. No, it is of no use, it is of no benefit also. And moreover, doing this, it increases complications like urinary tract injury might be there might be urinary tract infections or urinary tract incontinence also. In up to 22.5% patients they complain. So why do this? Why do all those things? So don't do routine clamping before removing the catheter, right? Next, lower limb bandaging as an anti-thrombotic measures. Sometimes in some hospitals we have been using that lower limb bandages like crab bandage, but this is outdated nowadays. It is not used. It cannot be a supplement. It cannot be a replacement for a compression stocking or for a DVT pump. So with the clinics, it's said that with the clinical practice guideline to prevent, diagnosis and treatment of venous thromboembolism in the obstetric patients as a good practice point, it is not recommended to use lower limb bandage as equivalent or substitute to compression stocking. So don't use lower limb bandage like crab bandage and all in replacement of the DVT stockings or DVT pump. It is no use. Just putting a bandage is of no use. It is outdated. Use of three-way taps in infusion therapy. The CDC guidelines, CDC in 2011 mentioned that three-way taps, the three-way we use sometimes, represents a focus of infection. Three-way taps can be a focus of infection and a potential entry point for microorganisms in vascular access and administered fluid. So three-way catheter should not be used because it might be a source of infection or might be a point of entry of infections. Current use is recommended to use of extension as an alternative to three-way tap. Use extensions. Lastly, sodium chloride 0.9% as drug diluent. We use sodium chloride in all cases of while we want to dilute an antibiotic or any other medications. We use sodium chloride. Instead of sodium chloride, use 5% dextrose because this will prevent hypernatremia to some extent, also prevent hyperchloremia. And if you use 5% dextrose, it has been found through studies that there is no risk of hyperglycemia. So instead of sodium chloride, use 5% dextrose as a diluent. The current recommendation is that the assessment of diluent effect was performed before and after change from sodium chloride, and there's a comparative study that before and after change with 0.9% and 5%, and there is a comparative study, and the incidence of hyperkalemia and hyperchloremia, hypernatremia, hyperkalemia, and also increase hypoglycemic and glycemic control are less when we use 5% dextrose. So prefer it. Thank you for your patience.